So moving to Amivantamab, somebody asked a question about the Chrysalis trial here. The Chrysalis trial is a study which looked at Amivantamab, a c-Met EGFR bispecific, and there are some cohorts where patients received that in combination with Lazertinib. Any updates on this study, and what is the efficacy of these two drugs in combination compared to OSI? Any ongoing studies in this space?
Sure. Yes, I know. I know I didn't really talk about EGFR exon 20 alterations in this setting, but amivantamab is a bispecific antibody, as I had mentioned, EGFR and MET. It's an infusion, and lazertinib is a pill. And I do think that there is some exciting data from the Chrysalis study. I think that the amivantamab alone, as we know, does not have great CNS penetration or penetration into the blood-brain barrier. However, lazertinib, a third-generation tyrosine kinase inhibitor pill, does. So the thought is that the combination of these two could be like a perfect marriage or best friends. That you have the amivantamab that hits the MET and the EGFR, and you have the lazertinib that penetrates into the blood-brain barrier. And the two of them are thought to function quite well. And I think, obviously the jury is not out yet in regards to this, but I think there is some promise here. I am enrolling patients in this study. I believe in this study. I think we need something. We need something post OC, and we need something to help those patients that have very recalcitrant or resistant CNS disease. And if they're progressing on OC, maybe lazertinib plus amivantamab is the right answer. Maybe not, but I think we need to try something. Dr. Sabari, what are your thoughts?
Yeah, no, I agree completely. I think that, in the second line setting post osimertinib, I really like to try to utilize other targeted therapy strategies. Bispecifics, for example, are exciting. There are also ADCs that you had mentioned, the patritumab deruxtecan, which targets HER3, as well as has a chemotherapeutic warhead. You called it a Trojan horse. I love that. It's also really important to think about maybe we can prevent the emergence of some of these resistance mutations by moving these therapies up front. So we had a question earlier about T790M, which was the most common gatekeeper resistance mutation to first and second generation EGFR inhibitors, but we don't see that in the clinic anymore. Really, it does not exist because, it's really covered by the third generation EGFR TKI osimertinib. So what are some of the resistance mechanisms? You mentioned MET and C797S. So how do we target those specifically? It could be very interesting to look at amivantamab and lazertinib in the front line. And there is an ongoing study now, the Mariposa trial, comparing lazertinib versus osimertinib versus lazertinib as well. So it'll be interesting to see that data. There's also an ongoing study of osimertinib plus the ADC, patritumab deruxtecan. So that'll be really, really important. And I do think that, as great as a drug as osimertinib is, I don't think it's going to be utilized in the future as a single agent. I think, in oncology progress, we need to build upon what we currently have, right? So, 19, 20 months before progression on a drug is not enough. We need more for our patients.
I agree. And I think just to kind of put another plug for a study at MSK, Dr. Helena Yu is the global PI for Orchard, which is a study that looks at patients that have progressed on frontline osimertinib. So there's 9 cohorts, and based on, if you have progression, we look for any of those resistance alterations. Do you have MET amplification? Did you develop a BRAF alteration? Do you have small cell transformation? Do you have squamous cell transformation? Any of those. And based on what your resistance mechanism is, you get put into a cohort that has that new targeted therapy involved in it. So you're basically put on treatment based on your resistance mechanism. I think it's a very well designed study. It makes sense. And it's looking to push the envelope a little bit more. So clearly, as Dr. Sabari said, we have lots of options of clinical trials in the post-OC setting, but there's no right answer.